Vital pulp autotransplantation of an open apex mandibular third molar after orthodontic activation. This case report, done by a Chinese group and published in the JOE, presents a biologically driven and digitally assisted approach to autogenous tooth transplantation using an immature mandibular third molar with an open apex. Emphasizing preservation of pulp vitality, the patient was a 27-year-old female who had lost her maxillary left first molar due to extensive caries and pulpal necrosis. After discussing treatment option, autotransplantation was selected as a conservative alternative to implant therapy, aiming to preserve alveolar bone, periodontal proprioception, and long-term biological adaptability. A key feature of the treatment protocol was preoperative orthodontic activation of the donor tooth. The impacted mandibular third molar underwent approximately 6 weeks of light orthodontic traction to partially erupt the tooth and biologically activate the periodontal ligament. This step was intended to increase periodontal ligament cellularity and vascularity, reduce extraction trauma, and facilitate atraumatic donor harvesting. Following orthodontic traction, CBCT and intraoral scans were merged for virtual planning, a high-yield fidelity 3D printed donor replica, Trifine compatible osteotomy guides, and seating guide were fabricated, allowing precise and standardized preparation of the recipient socket before donor extraction. Surgically, the recipient site was prepared using guided Trifine osteotomy, minimizing manual adjustments and ensuring congruency between the socket and the donor root morphology. The tooth was extracted atraumatically using piezo-assisted techniques with extra alveolar time, limited to approximately 20 minutes, and the tooth stored in platelet-rich fibril. The transplanted tooth was seated using dedicated guide to control angulation and depth, then stabilized with sutures and flexible splint. Importantly, no prophylactic root canal treatment was performed due to an open apex and high potential for pulpal revascularization. Clinical and radiographic follow-up over 24 months demonstrated favorable healing. Serial periapical radiographs showed progressive trabecular bone formation, maintenance of crestal bone height, and absence of inflammatory or replacement resorption. At 2 years, the transplanted tooth was asymptomatic, functionally integrated, and exhibited a positive response to electrical pulp testing, indicating maintained pulpal vitality. CBCT imaging confirmed near complete apical closure and stable alveolar bone around the transplant. Additionally, the donor site showed satisfactory bone regeneration without periodontal compromise of the adjacent second molar. Overall, the authors highlighted that the orthodontic donor activation combined with digitally guided surgery can enhance biological outcomes and procedural control in vitally preserving autotransplantation. So the study is limited by its single case design, lack of control group, unquantified orthodontic forces, and relatively short follow-up, which restricts generalizability and long-term interpretation.